Good afternoon, everybody. My name is Sharon Rounds. I am the PI for Advanced CTR. And today we're delighted to have the first of our Advanced CTR clinical and translational research seminars. These seminars feature distinguished clinical and translational researchers from our partner institutions, as well as emerging new investigators. Today, we're really delighted to have Dr. Caroline Richardson with us. Dr. Richardson is the George A. and Marilyn M. Bray Professor and Chair of the Department of Family Medicine at Brown University and Chief of Family Medicine at Care New England. Dr. Richardson is expert on improving quality of care for type 2 diabetes in primary care settings. We were fortunate to recruit her to Rhode Island in 2022 from the University of Michigan, where she was leading the statewide Michigan Collaborative for Type 2 Diabetes. Her research has been funded extensively by the National Institutes of Health, as well as the Department of Veterans Affairs. And she is clearly recognized as a leader nationally in this field. So we're really delighted to have her with us. We will ask people to enter their questions into the chat, and we'll be addressing those at the end of Caroline's presentation. So again, thank you very much and for your attention, and thank you, Caroline, for joining us today. She'll be talking about new approaches to type 2 diabetes. Take it away.
Thank you, Dr. Rounds. Okay, so now it's not. Fabulous. I'm going to stop sharing and reshare to make this work. There we go. Okay, so new approaches to type 2 diabetes is what we're going to be talking about. Dr. Rounds just gave a little introduction, but I just wanted to give a little more detail about how I came to be working on type 2 diabetes. I'm a family doctor. I've been practicing as a family physician for about 27 years. Spent a lot of time as a VA investigator in Ann Arbor at the Ann Arbor VA. While I was in Ann Arbor, I took the lead on a number of national initiatives around type 2 diabetes management. I started really working mostly on diabetes prevention, and with a particular focus on how we change health behaviors and the use of objective monitoring. So before we had Fitbits, we did a lot of the work developing the algorithms and strategies for using objective monitoring, remote objective monitoring around physical activity. We also ran a big trial for the VA around diabetes prevention, and I led the Diabetes Quality Enhancement Research Initiative while I was there as well for the VA. My more recent work, which is what I'm going to be talking about today, is focused on managing type 2 diabetes with continuous glucose monitoring and lower carbohydrate diets. And also a little bit, we'll touch on some of the newer medications for type 2 diabetes that we're helping to roll out. Lastly, I spend a fair amount of my time as editor of Annals of Family Medicine, which is the research journal for Annals of Family Medicine. It's an international journal. So that's who I am. I'm going to go ahead and talk a little bit about preventing and reversing type 2 diabetes. I'm going to start with this slide, which is a screen capture from an NIH website that was up. I captured this a couple of months ago. But basically, I want to point out what it says about type 2 diabetes. It says, while a number of therapies are approved for type 2 diabetes, none can reverse disease progression over the long term or prevent complications of the disease. And that's just not true. We know it's not true. And especially over the last 5 to 10 years, we've developed a number of strategies that can reverse disease progression and that can prevent complications and can have long-term impacts on people's health and outcomes. There's a lot of debate and a lot of scientific argument and disagreement about what we should call this. Should we call it reverse? Should we call it remission? Should we call it, whatever. The fact is that we can take somebody that's at a certain state of diabetes and we can move them to a healthier state and that we can keep them there. It's not easy. There are adherence issues. There are all kinds of things going on, but there are a number of different strategies that are very effective at taking people who have diabetes and turning them into someone who looks, for all the world health-wise, like somebody who doesn't have type 2 diabetes anymore. We're going to be talking about some of those newer strategies for reversing diabetes, but keep in mind that this is really a new way of thinking about diabetes. It's different than what you might hear or read about in a lot of different textbooks around diabetes, and it is relatively, it's a new perspective, but an incredibly exciting perspective. Type 2 diabetes is such a burdensome disease from a cost and morbidity perspective. To be able to reverse it and prevent it is really important. So here is a screenshot of a paper from 2002 in the New England Journal of Medicine. This is the diabetes prevention program paper. We know we can prevent diabetes from this paper, and 7 other national scale trials from other countries have shown similar results. Type 2 diabetes is preventable with diet and exercise alone, much less all the new medications and other strategies we have. We know, as well as we know anything in medicine, that we can prevent type 2 diabetes with diet and exercise. But we also have new research over the last 10 years that has shown other proven strategies for preventing and reversing type 2 diabetes. Weight loss, healthy diet, and exercise can certainly do this. Low carbohydrate diets have been shown to take somebody who has very poor diabetes control on multiple medications, get them completely off those medications, and have normal glycemia. GLP-1 receptor agonists also show promise in this area as causing massive weight loss, reducing insulin resistance, and resulting in taking people who have diabetes to people who don't have diabetes. If you're on a GLP-1 receptor agonist and your sugars are normal, is that treated diabetes or is that reverse diabetes? All these are debates we can have in some academic setting, but basically these are strategies that can be used to take people who look like they have diabetes and make them look like people who don't have diabetes. Bariatric surgery is another strategy that has been shown to reverse diabetes in about 50% of people who get it. The reason I have bariatric surgery listed here in brown instead of black is I'm not really going to talk about bariatric surgery. What I'm going to talk about is those strategies that we use in primary care and family medicine. And I'm not thinking we're going to start doing bariatric surgery in the clinic anytime soon. So I'm leaving that as a separate issue. But we are going to talk a lot about diet, exercise, particularly low carb diets, the new medications that we are using for diabetes, and then an additional sort of supporting strategy, which is using continuous glucose monitoring in type 2 diabetes. Again, I'm not arguing that these issues don't have sustainability and adherence issues over the long term. Those are all subject to research, and new strategies are needed for all of those things as well. So our objective is to objective for the purpose of this talk is to convince you that we can reverse type 2 diabetes effectively, and that there are lots of strategies that we can do that with, and that these strategies can be deployed in primary care settings. It's important that they can be deployed in primary care settings because the volume of people with type 2 diabetes is very high, and there aren't enough endocrinologists or obesity experts to deal with the number of people who have type 2 diabetes. And one of the things that we need to do is get some of these newer strategies out to the primary care offices where they can get to the patients who need them at scale. So we'll be talking about implementation strategies and ways that this can work in a primary care office. I'm going to review data from 2 different studies and a large collaborative that we had in Michigan. So we're going to start with the first study, which is a study about low carbohydrate coaching plus continuous glucose monitoring for type 2 diabetes patients. This trial was a pragmatic, randomized controlled trial. And the design of the trial is kind of one of the more interesting things about it, plus the results were interesting. But I'm going to spend a fair amount of time discussing how and why we designed the trial the way we did. So again, we have 2 components to the intervention: coaching around low carbohydrate eating and using a continuous glucose monitor. Traditionally, continuous glucose monitors have been used in type 1 diabetes, not so much in type 2, but as they become cheaper and easier to use, they're now being used more often in type 2 diabetes. And in type 1, they're often used to adjust insulin dosing. In type 2, they're more frequently now being used to help patients learn how to eat healthier diets that don't cause massive glycemic excursions. Low carbohydrate diet coaching is also a little bit controversial at this point, and I'm going to spend a little bit of time talking about what I mean when I talk about low carb and some of the different options there are there. So low carbohydrate is a kind of a vague term, like how low? What are we talking here? So very low carbohydrate diets are sometimes called ketogenic diets. Or keto diets. And those diets tend to have less than 50 grams of carbohydrates a day, often closer to 20 or 30 grams of carbohydrates a day. For most of what I'm going to talk about in the first trial, at least in the first trial, we'll be talking about low carbohydrate diets with 50 to 130 grams of carbs a day. The second trial I'll be talking about will be a ketogenic trial. And then the typical American diet has, more like 225 to 325 grams of carbohydrates per day. And also that's the American Diabetes Association standard diabetes diet is about 180 grams of carbohydrates a day. So there's different degrees of low in the low carbohydrate spectrum. For the first trial, we're going to be talking about low carbohydrate. And for the second trial, we're going to be talking about very low carbohydrates. Funny view of what low carbohydrate and keto means, often thinking that it's just a big slab of beef. But really, for taking people who are on a standard American diet and switching them to low carb, often what that means is just cutting out sweets and sodas and switching to vegetables that are lower carb, less starchy vegetables. And the fat content of a keto diet is often relatively high. And compared to the lower fat diets that have been traditionally recommended as healthy diets, and compared to the traditional American Diabetes Association recommendations. So sometimes we have to add back in fat to the diet, but for the most part, even after we get rid of all the sweets and sugary and grains and breads and potatoes, we end up with patients who are already eating plenty of fat, and we just need to switch out those carbs for healthier vegetables. And then just again, reinforcing diet with the continuous glucose monitoring. When we change a diet, we often have to also change medications. So as we decrease carbohydrate load in the diet, patients come off of their diabetes medications immediately, within 24 hours. Their sugars will drop as they drop the carbohydrate load in their diet. This is known to anyone with type 1 diabetes who monitors their carbohydrate load to dose their insulin preprandially. But we know it in type 2 diabetes, it's the same. If we cut carbs out of a diet and drop them to 50 grams of carbohydrates a day or 100 grams of carbohydrates a day, down from 300 grams of carbohydrates a day, we will have to drop their insulin dose, or other medications will have to be backed off on to avoid hypoglycemia. CGMs really help with both teaching people what they can eat and what triggers their sugar to go high, but also in managing the taper off of the medications as they switch to a lower carbohydrate diet. So there's a very strong synergy between CGM and low carb diets that we were leveraging in this trial. We used a diet that was developed by a guy named David Ludwig. He's a endocrinologist up at Harvard. And he produced a fairly easy to use and user-friendly book that explains his diet and theory. It's basically a pretty standard low carbohydrate diet with some good recipes and a good explanation in it that we use in our trials, and we use some of his materials off his website as well. CGMs are now pretty cheap. The cost is somewhere between $250 and $5 a day. It's dropping rapidly. The usability is about as good as a Fitbit. Accuracy, some people say that's not accurate. And if you had type 1 diabetes, you might want one of the more sophisticated CGMs, but the cheaper CGMs, like the Abbott Libre that we use in this trial, have good enough accuracy to do what we want to do, which is help people wean off of medications while they're lowering the carbohydrates in their diet, help people learn what foods change their glycemia. This is an Abbott Libre 14-day sensor for a continuous glucose monitor. It has a tiny monofilament that goes into the skin, under the skin, and senses glucose that's in the intercellular space. Here are some tracings that come from a CGM. The sensor number 1 is what we put on a patient who came to us with major glucose excursions, including the yellow areas where the glucose went too high, but also the red areas where the glucose went too low. And in type 2 diabetes, we see a lot of hypoglycemia and a lot of hyperglycemia sort of simultaneously in the same person because of these big excursions. After a 1-hour coaching session by a dietitian on how to lower carbohydrates in the diet, you can see that towards the end of the first sensor, they started to even out and get rid of some of their highs, but still had a few lows. And after a week later on the second sensor, they basically were able to maintain most of their time in the normal range, which is the gray bar across the graph for each day. Still remaining on I could say Monday, November 5th, you can see those hypoglycemic episodes probably still need to back off on some of their medications to get them to avoid that hypoglycemia as they continue to lower the carbohydrate doses in their diet. Here's what it looks like in our trial. We give patients a log. We ask them to log their food. We show them how it matches up to their CGM, what they eat when they eat it. And our patient, quote from one of our patients, "I was more conscious of it. I was able to see in real time what I was eating was doing to me." You can listen to dietitians and all this other stuff, and if you can't really see it, you don't know, you don't realize. So this is what we're using CGM for in our trials. And here's another quote from one of our patients about the CGM. "I enjoyed using the CGM. It allowed me to see the different effects foods have on my sugar and to be able to make better food choices. By making better food choices, I was able to lower my insulin." So the trial, how do we implement this low carbohydrate diet coaching and CGM for type 2 diabetes in a clinical setting? We went to a large clinical practice in Chelsea, Michigan, big family medicine clinic. And we took every single patient in that clinic who had type 2 diabetes and was 21 or older. And we didn't ask the patients if they wanted to be in our trial. We didn't consent them. We didn't talk to them. We just got a registry of every single diabetes patient in the clinic. We went through and excluded patients who we thought wouldn't benefit from tight control. So patients who were on hospice or patients who were fighting end stage of a serious disease, a cancer or something like that, we removed from the registry. Patients whose physicians said they had significant cognitive or mental health barriers to being able to participate in a behavior change intervention, patients who were pregnant or breastfeeding, and patients who had previous bariatric surgery were also removed from the registry if we knew about that. And then we took that registry and we took that registry and we randomized people into two groups, the enhanced care and the usual care group. There were about 1,500 patients in the clinic who had type 2 diabetes as a diagnosis on their chart. We split them in half and got about 800 patients in each of the arms. And then we we looked at who was poorly controlled and who was well controlled in the two arms, and we created these high risk usual care group of 250 patients and a high risk enhanced care group of about 250 patients. That was our main concern, was could we take the patients who were poorly controlled in these two groups and make a difference in their care. We then, after excluding the patients who had met the exclusion criteria, we were left with about 200 patients in each group. And you can see the primary comparison arrow tells you what our main outcomes were going to be. 185 people who were invited to participate in the low carb coaching plus CGM group in the enhanced care arm of the high risk patients did not all agree to be part of the enhanced care intervention, but all 185 were included in the main analyses as intention to treat subjects. Of the 185 patients who were invited to participate, we were unable to contact about 50 of them. They didn't respond to our emails or calls or when we couldn't find them in clinic. So of those who we did contact, we got about 61 to agree to participate. Of those 61, we got a subset of 49 of them who agreed to allow us to look in more depth in their medical charts, signing informed consent for us to continue to use their medical information and their information about their medication prescriptions long-term. What I'm going to focus on first is the usual care to enhance care primary comparison. So this is kind of a complex design. And before I move forward, I want to just talk about why we use such a complex design. Why not just ask people if they, ask 120 people and recruit 120 people, 60 in the control arm and 60 in the intervention arm would have given us the same sort of effective sample size at the end. But we really wanted to understand from an implementation perspective, how many people would be eligible for the program, how many people would be appropriate for the intervention, and how many people would agree to try the intervention. And that's important for implementation strategies in the future. And so we wanted a well-defined risk pool. All right, so here's the baseline characteristics of the patients, and you can see across the top the list of different subgroups that we looked at baseline characteristics in. And the initial column is all patients, all 1,584 patients in the practice, and that's just a standard family medicine practice. Patients who have type 2 diabetes, they generally had a higher BMI than average, a 35 BMI on average. A1C was about 7.2, so reasonably well controlled across the practice. As you move across, you can see we divided the two groups into the usual care and enhanced care group, pretty comparable across all those metrics. And then we limited them down to just those who were poorly controlled in the high risk groups. So usual care high risk group had a baseline A1C of 8.9, so significantly worse control, and enhanced care high risk group of 9 had a baseline A1C of 9. So this is a poorly controlled group of patients. And then among those 61 who agreed to participate in the program, their baseline hemoglobin A1C was 9 and their baseline BMI was 37. So here's the primary comparison after we completed the trial. For hemoglobin A1C, we did see an improvement in the usual care arm of about 0.47 reduction in hemoglobin A1C. For the patients who were in the enhanced care arm that got the CGM, got offered the CGM, didn't necessarily use the CGM, but got offered the CGM and got offered low carb coaching, we saw a reduction in hemoglobin A1C of 0.88, so almost double what we saw in the usual care arm. And that was a statistically significant difference with a p-value of 0.04. BMI, we saw reductions in BMI in both arms, but the BMI reductions were not significantly higher in the enhanced care arm than the usual care arm, which is a little bit of a disappointment to us. We thought with low carb eating, we'd see weight loss, but the total trial was 4 months long. Patients were in the trial for 4 months. sorry, wrong trial. This was a year-long trial. So that was after a year, we saw this level of weight reduction. If we had used a very low carbohydrate diet, we may have seen a larger reduction in weight. But we also thought, well, remember, this is intention to treat. Only 61 patients actually engaged in the intervention in the enhanced care arm. So maybe we would see weight loss if we just looked in those 61 patients who actually used the intervention pre and post. And so we're dropping down to looking in the 61 patients who engaged in the enhanced care program, and we saw that for them, we did see a larger drop in BMI, but still not a statistically significant, depending on if you believe in the p-value cutoffs of 0.05, we're just at 0.06. And we saw a pretty dramatic reduction in hemoglobin A1C of 1.1 at the 12-month difference among those 61 who actually participated and engaged in the intervention. So we did qualitative interviews of the patients who participated. This patient says, I really reflected on portion control with that study because I noticed the types of food I was eating. I would jack my sugar up, way up or down based on what I was eating. Like a protein shake, even though it said it was low carb and all that, my sugar levels would raise and stay up for quite a while versus eating like a boiled egg, and a piece of toast. It would be more even. So I learned that some foods are better for me than other foods. So this is a really important quote because it emphasizes that our patients learned what worked for them from a glycemia standpoint. And it's not necessarily only about carbohydrate intake. It may also be about the other things you're eating, how much protein, how much fiber you're getting, and allowing patients to see what actually happened when they ingested different foods using the CGM was an important part of the educational component of the intervention that allowed them to be successful. I'm going to look down to the bottom group on the flow sheet, which is the group of 49 patients who agreed to let us look at their medication changes in more depth in their chart. And what we were able to find was that there were changes in the monthly cost of anti-hyperglycemic medications, particularly in those who were started out on insulin, as insulin is expensive. We saw the changes were not statistically significant pre-post, but were trending towards a reduction in costs across the board. What we do know from this data is the improvement, the 1.1 reduction in A1C that was seen in the 61 patients who participated in the intervention did not come from medication intensification. This was strictly a change in diet, and often for many of these patients, a reduction in medication use, resulting in the outcomes that we saw. So why did it work? CGMs give immediate personalized feedback about the impact of actual food choices on glycemia. The low carbohydrate coaching gives patients control. And the reason I put this in here is because there's a lot of stuff in the literature about how testing your blood sugar when you have type 2 diabetes doesn't do anything. There's all kinds of trials that actually show that testing your blood sugar if you have type 2 diabetes and you're not on insulin has no impact on your outcomes. Blood sugar doesn't do anything to your blood sugar except tell you what it is. It's what you do with that information after you test that changes your blood sugar. And in most cases, we tell people to test without telling them what to do about it, other than adjusting medication doses or intensifying medication. In this trial, we actually coach people about how to change their diet and use the data from the CGM to help them change their diet. Once we gave them that kind of control over what their CGM was going to show them by explaining why it was going up and giving them the tools they needed to change their diet and control it, they had this positive and empowering and learning and growth approach that was well received by the participants and actually is effective in improving glycemia and other outcomes with type 2 diabetes. All right, study number 2. I'm going to move on from that last study to a study. The last study, remember, was a low carbohydrate coaching. This is a very low carbohydrate study, a keto study. And this study was published recently just a few weeks ago, and it's gotten a lot of attention because it is comparing a diet that's very well accepted in the medical world, the DASH diet, to a diet that is scorned in much of the medical community, the keto diet. The DASH diet was developed specifically to address hypertension, and it focuses a lot on reducing salt intake. But otherwise, it's a relatively traditional, healthy diet, vegetables, reduced, particularly saturated fats. In some ways, it's different from the keto diet because it does tend to focus on lower fat content as well as low salt content. The keto diet has a higher fat content, much higher, and doesn't emphasize staying away from saturated fats. So what we did was we wanted to compare the DASH diet to the keto diet with respect to hypertension. The DASH diet is specifically designed for people with hypertension. It's accepted as the best diet for hypertension. It's what the cardiologists all recommend. We thought we could compare keto, that keto might do a better job at lowering systolic blood pressure than the DASH diet did in patients, particularly in patients who have three diseases. That is, they are obese or overweight. That's one of the diseases. Second disease is they have diabetes or pre-diabetes, so they have dysglycemia. And the third is they're hypertensive with poor control. So primary outcomes: hypertension, systolic blood pressure. And we're basically comparing keto to the gold standard of diets for hypertension. The reason we thought that keto might do better than DASH is because keto is a diuretic diet. When you stop eating carbohydrates, your body loses a lot of fluid, and losing fluid brings down blood pressure. And so that was one of the hypotheses. Additionally, keto causes weight loss. Weight loss also reduces blood pressure. This trial is a 4-month trial, and the 4-month trial may not have given enough time to see a dramatic reduction in weight, although we did see a reduction in weight, but it was enough to lower blood pressure, to lower weight, and if it were sustained for longer, it might have done even more. So that's the setup for the trial. It's a randomized controlled trial for patients with triple morbidity: hypertension, dysglycemia, and overweight obesity. The other reason we did this trial is most patients don't just have hypertension. Most patients who are obese have all hypertension and diabetes. And so we're seeing a lot of patients in our clinic where we're like, well, which do we give them? Do we try the DASH diet for their hypertension? Do we try the keto diet for their weight loss and their diabetes? What if you have both? That's a common problem with the research that's out there. It doesn't address people with multimorbidity. So we did a study design. Again, it's a little bit of an unusual study design. It's a 2x2 factorial design. Factor 1 was the diet, DASH versus keto. Factor 2 was support, standard online education versus sort of enhanced online education with behavioral coaching and some other tools to keep people on board with the diet. And that the support group was just to say, well, we don't want to just compare DASH to keto without intensive behavioral support and see no benefit of either diet. We want to see if, what does it take to get this to actually work? And if we give that support, will it work? Will one work differently than the other? So back to this 2x2 factorial design, all of the results in our trial showed that support really didn't have a big effect. And there were no statistically significant impacts of support. So all the results I'm going to show you now, we've collapsed factor 2, and we're just going to show the DASH versus keto results. So here's the consort flow diagram for the trial. This is a relatively small randomized controlled trial, considering that it's a 2x2 trial, a 4-arm trial. And there was a little bit of loss to follow up, but not a lot. Ideally, this trial would be replicated in a larger setting. So the intervention for this trial is a weekly 4-month online program, 16 weekly sessions. So online, automated, low cost, easy to scale, easy to disseminate. Text messaging, patients were mailed cookbooks, and they got email-based coaching from a live coach at least every 2 weeks. patients were taught and encouraged to self-monitor nutritional intake, weight, and blood pressure. They were also encouraged to use blood glucose monitoring if they were on diabetes medications. And they were recommended to start a physical activity program if they weren't already doing it, and to work on their sleep hygiene starting at week 6 after they'd hopefully gotten sort of the low carb diet under their belts and knew what they were doing with that. Again, the very low carb diet, keto diet, 20 to 35 non-fiber grams of carbohydrates a day. Also, they were testing their urine for nutritional ketosis. So that was a goal, was to teach them how to get into ketosis. The DASH diet was a traditional DASH diet, which is a low sodium, low fat intake diet. And so that was what the recommendations were for that. So here are the results. The keto beat DASH on all 3 outcomes, including the primary outcome of systolic blood pressure, where basically the change in systolic blood pressure in the very low carb keto diet was about 9.77 millimeters of mercury. The change in systolic blood pressure for the DASH diet group was about 5.18 millimeters of mercury. So almost double reduction in systolic blood pressure for the keto diet versus DASH. Hemoglobin A1C, similarly, reduction of 0.35 in the keto diet and 0.14 in the DASH diet. So almost more than double reduction in hemoglobin A1C with the very low carbohydrate diet. Similarly, reduction of almost 20 pounds in the very low carbohydrate diet. Remember, this is over 4 months, and a 10-pound reduction in the DASH diet over 4 months. So almost double. So the keto beat DASH in all 3 outcomes, including the primary outcome of systolic blood pressure, and was basically twice as effective across all 3 of those outcomes. So, so this has gotten a lot of attention in the press about whether we should be treating our patients who have systolic blood pressure with lower carbohydrate diets rather than the DASH diet. As you can imagine, there's been a lot of debate about changing from something that was so well accepted in the past. So the last thing I want to talk about is the Michigan Collaborative for Type 2 Diabetes. MCTTD is a large statewide collaborative to improve quality of care for diabetes that we put together. Part of it is because we have these new drugs, Ozempic, Wegovy, Mounjaro, that you may have heard of, that are weight loss drugs that not very many primary care doctors were familiar with or know how to prescribe, and everybody's asking about them in primary care. Partly it's because the American Diabetes Association recently changed guidelines to really focus on these newer drugs, and to sort of put insulin at the end of the line for type 2 diabetes. We're really not recommending insulin as a treatment for type 2 diabetes anymore. It's not the best option. GLP-1 receptor agonists and SGLT2 inhibitors are better drugs for type 2 diabetes almost across the board. And insulin is, if they can't take SGLT2 inhibitors or GLP-1 receptor agonists for some reason, insulin may be a second choice, but it's not optimal care. So the problem is that most people with type 2 diabetes are treated by primary care doctors and family doctors, but most primary care doctors don't know how to read and use data from a continuous glucose monitor. They don't know how to coach about low carbohydrate diets, and they don't know how to prescribe these newer, better medications. The MCT2D was designed to help support physicians across the state of Michigan to learn how to do these things and implement them in their clinics in a population level impact way. Blue Cross Blue Shield of Michigan funded the collaborative, but it was an all-payer collaborative, meaning that any patient who had any insurance company could participate and benefit from the collaborative interventions. Another unusual thing about the collaborative is that it was we had a huge investment in design and communication and patient voices, and we'll talk about that in a minute. So here's the MCT2D website, and what it really contains is just a lot of resources to support physicians. These resources were developed with patient input, with primary care physician input, and with designer input to make them as usable and accessible as possible. Here's the map of the practices in Michigan that are participating, and it's over 1,000 primary care docs at this point are engaged in the practice, in the consortium. Here's one of our design tools to help educate physicians about the new strategies for type 2 diabetes. And this is a roadmap of what might happen to a patient if they did the old strategies for diabetes management versus the new strategies for diabetes management. So the top road is the old strategies, and the bottom road is the new strategy. So you see a patient who comes in with 260 pounds on metformin and insulin, and their hemoglobin A1C is 8.2. And on the top road, they do the traditional strategy of fixing that 8.2, of increasing the insulin. So the syringes show increasing insulin. The insulin increase causes a 10-pound weight gain, but does in fact improve their glycemia. So their A1C drops from 8.2 to 7.6. Still not perfect, so add some more insulin. Gain 30 pounds, but now the A1C is back in a good range. Alternative approach to managing this patient would be, instead of adding insulin to help bring down the 8.2 A1C, would be to teach the patient to eat a lower carbohydrate diet and give them a continuous glucose monitor to help support that behavior change. Quickly lose 10 points and see the same reduction in hemoglobin A1C they would have seen had they increased their insulin dose as they did on the higher road. Subsequently, add a GLP-1 receptor agonist to their medication regimen and take them off of their insulin. They lose 30 pounds, come completely off their insulin by the end, and have good glucose control. So the difference between the 30-pound weight gain and the insulin resistance that's conferred by that 30-pound weight gain from the insulin increase road on the top versus the reduction in weight, the decrease in insulin resistance, and the increased level of energy and ability to move that we see on the lower road is the difference that we're talking about. And then I'm going to go to the next slide. Here's some of the materials that were designed by our design team, by our patients, and by our primary care doctors input across the state. A low carbohydrate eating starter guide that's free for patients. This has been used actually around the world at this point because it's accessible and usable. We have them in Spanish as well. Most of our materials have been translated. And then here's a handout that was an information sheet that was given to primary care doctors across the state that's organizes a whole lot of information about one of the new classes of medications, SGLT2 inhibitors. One of the reasons PCPs don't like to prescribe these newer medications is because they do have side effects, they do have risks, and there's a fair number of them to keep track of. And this is an easy way to understand which of the side effects are severe, which of the side effects are common, which ones are rare, which ones are things that we're concerned about, but we don't know if are actually real risks yet. So how to organize all that information visually using color coding to make sure that the primary care doctor can glance at it, see what they need to worry about quickly, and have all the information at their fingertips rather than a text-based presentation of the same material. So that's the design element that we were talking about. And then we also included patient voices in everything we do. And I'm actually going to stop sharing. Oh, I may have to stop sharing. Okay. And we're going to play a video of one of our patients that we use. And we can't hear the video.
That he was diabetic and he was trying to keep it. I caught a guy at work one time because I recognized the sound of the snap, that he was diabetic and he was trying to keep it a secret. But every couple of hours or so I could hear it going click, 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 because I knew that even though you have your clicker turned all the way up, sometimes it don't get through your skin. And you have to stab yourself several times. I call it stabby McStab face. You know what I'm saying? Sometimes when you use the needle, you know what I'm saying, the prick, you're okay. Sometimes you hit the end of that nerve and you jump out of your skin. Okay? With the CGM, nope. One tom and gum. You're this thing here, you put it on, and I can check 200 times a day. You know, it's like, it should be a no-brainer. If I see readings that are like, kind of thing, well, then I'll keep a tighter eye on it till things get under control. In other words, if I'm at a situation where I'm trying to eat something or wanting to eat something, like a dinner with other members of the family, I can look at my readings, and if it's like, you know, 190 or something of that nature. It's like, nah, I better not. You know, you pick out something like broccoli that's at the table, something that has no impact on your blood sugar, and just eat that. Because again, it helps you. It helps you stay incognito. You know what I'm saying? I like the way it works. I like the fact that my doctor can look at the Libra view and she can see everything, because they would make me handwrite things down in a spiral binder, and I had to bring a spiral binder into them. And, you know, I mean, Dr. Yu and I worked on a spreadsheet, but even the spreadsheet didn't want to work because the U of M doesn't want to take a spreadsheet from a stranger. You understand this?
Okay. All right. Okay, so that was one of our patients, and I just wanted to show that because we use patient voices in all of our trainings for our physicians across the state. And because they have perspectives about what it's like to live as a patient with diabetes, and the advantage of a CGM, we think about it helps us prevent bad outcomes. It helps us dose your insulin. It helps us, maybe helps us help you change your behavior. But patients really think about it helps me not have to stab my finger with a needle 5 times a day. So there's just different perspectives that we see from actually using some of these new strategies. I wanted to talk about one of our newly funded R01s that we're working on now, because eating behavior is very similar in many ways to substance dependence and works through similar dopamine channels. We're going to use continuous glucose monitoring and some testing and assessing that we normally use in substance use to look at carbohydrate addiction and carbohydrate withdrawal and how that affects the activation of the reward circuitry. That was just funded recently. So that if anybody's interested in working on that with us, that's a good direction. It's also interesting that the GLP-1 receptor agonists, the new class of drugs that help with weight loss, seem to have an effect on the same reward circuitry pattern, and are being used in addiction treatment for alcohol and other substance use disorders because they share that reward circuitry. And then just a quick slide about funding and other team members. We've had a lot of funding from Twine Consulting for that first trial. The second trial was funded from a University of Michigan interdisciplinary team grant. The consortium was funded by Blue Cross Blue Shield, and we've had funding from NIH and the VA and RWJ that's contributed. And then major collaborators, particularly wanted to call out Dina Grousdy, Kara Mizukami-Stout, and Melissa DeJonker. All 3 of those people are actually my K-Grant mentees, but I learned as much from them as they learn about from me, and they participated in a lot of the work for all of these trials and consortium. Dean is going to be actually giving a talk here in the Department of Family Medicine about obesity treatment, which I'll mention in a minute. Laura Saslow is the expert on keto diets. Lauren Ochman took over the MCTDD in Michigan, and Radhika Papusu is an endocrinologist who has helped me with a lot of this work. And this is Dina's talk, which is going to be on September 21st at 4:00. If you're interested, it will be Zoom call. It will be Zoom and in person. If you want to do the Zoom call, let me know. I'll get you the link. And that's it.
Bravo. Thank you. Oh, my video doesn't seem to want to start. Thank you so much, Caroline. A couple of questions. One is, does when you change the glucose, do you have evidence that the microvascular changes caused by diabetes are also reversed? I'm thinking, I don't know, like basement membrane thickening, for example, or other vascular complications?
Well, so you asked that a specific way, and I'm going to answer that specific way. When we change the glucose, every trial we've ever done that looked at microvascular complications has shown that if we change the glucose, we improve those outcomes. Has there been a trial looking at those specific outcomes that change the glucose in a specific way by using a low carbohydrate diet? I would say there have been small trials that have been done, whether they're convincing or not. That would depend on your perspective. We could do better in documenting the effects of a very low carbohydrate diet on some of those factors. But if you think that the primary mechanism is lowering glucose, then that would not be a question anymore.
Great. So Steve Kogut from the University of Rhode Island says, excellent talk, thank you. Any concerns about longer-term lipid and renal effects of very low carbohydrate diets?
So first, there's a misconception that eating a very low carbohydrate diet, which is a high-fat diet, results in poor, bad lipid outcomes. That is not true. For most patients, there are exceptions. A small percentage of patients who go on a very low carbohydrate diet will have a significant adverse effect on their lipid profile. And we do monitor for that in all of our trials. And we recommend that people starting a very low carbohydrate diet get their lipid profiles checked before they start and afterwards. Many patients who lose significant amounts of weight from a keto diet or even a low carb diet will have improvements in their lipid profile because of the weight loss. For those people who don't have improvements or who have significant worsening, that's a discussion that needs to be had with that patient about risks and benefits, and about other strategies to manage the dyslipidemia. For the renal effects, there's actually good trial data now that show that a very low carbohydrate diet is renal protective. And that was trial data that was presented at the American Diabetes Association meeting just a few weeks ago, actually. I'm not sure it's been published yet, but it was pretty convincing data. And also not surprising that when you improve blood pressure, which we saw this does improve blood pressure, when you improve weight, you get better, and when you improve glycemia, you get better renal outcomes.
So just thinking in terms of cost benefit analysis, obviously, being able to get patients off expensive diabetes drugs would be a great benefit. But it strikes me that the type of counseling that is required for these strategies to work will entail the use of ancillary personnel, such as nutritionists or nurses or whoever. Have you looked at the cost benefit effects?
So the new diabetes drugs are very expensive. Insulin is very expensive. GLP-1 receptor agonists have somewhere between $8,000 and $10,000 a year. SGLT2 inhibitors around $7,000 a year. You can do a lot of counseling in person, one-on-one for that much money. But it's important to think about the fact that in our DASH versus keto trial, the intervention was not one-on-one coaching. The intervention was primarily automated emails and text messaging, and there was a little bit of one-on-one coaching. Every 2 weeks, we would send them a personalized email, but very limited one-on-one interventions, and it worked.
Okay.
So people were able to lower their glycemia. In the first trial, we used a one-on-one dietitian, but fairly limited, 6 sessions over the year maximum. And most of the patients didn't even use those 6 sessions. So probably average around 4 sessions with a dietitian. 4 hours of a dietitian's time is not $8,000. And we also added in 6 CGMs over the course of the year, $75 per CGM. That's, that's again, not $8,000. So we can deliver, we've demonstrated in our trials that we can deliver this at a fairly reasonable cost, much less than the cost of these medications, whether it's insulin or SGLT2 inhibitor, GLP-1 receptor agonist.
Anya, your hand is up.
Hi there, and sorry I'm off camera. I'm in my car, but pulled over to the side of the road. Caroline, thank you. That was a fascinating presentation and just seems so pragmatic, to use that term. And I'm wondering, a couple things really strike me. One, first, that we don't have enough people listening to this. And so would be interested in your ideas about other ways that we get this out, because I think we've had fewer than 20 people listening in on this. Jeffrey Borkin, bless his heart, has been here for the entire presentation. But I would love to explore with you. I'm the administrative director of Advanced CTR, by the way. I'd love to explore with you other ways that we could get this out to others in the community. Second, how do you get this out into, I'm interested in how does this actually get implemented? How does it get into practice? Where do you go from here in terms of advancing this knowledge and incorporating it into practice? And third, I'm really intrigued by the little clip from your patient participant, because a big part of advanced CTR is sort of community engagement, and how do we bring the voice of the community and the voice of the patient in. And I think that was a great example of like what matters to the patient. I don't have to stick my finger every day. So I love that example. You don't have to comment on that, but I just thought that was really helpful in terms of our particular perspective.
Yeah, so thanks for all those comments. The consortium in Michigan is disseminating this work very effectively, and we're able to track that. So the strategies that were used in Michigan to get the over 1,000 primary care docs on board with some of these new treatments for type 2 diabetes, get them up to speed and find ways to implement CGM and things like that in their practices, has been effective. I wouldn't say it solved all the problems, but we've definitely accelerated the dissemination of these strategies to the patients with type 2 diabetes in Michigan. The single most important part of that consortium, which is never part of anything we ever think about when we disseminate, was our design team. Our design team was able to create communication tools and materials that were extremely effective, including those videos of patient voices. And so that was really the key. And I think if we're going to think about ways to disseminate anything in medicine that we know works but isn't being used effectively, we need to stop thinking about research on doctors and start thinking about engaging design teams. Here in Rhode Island, we have the world's best design school down the street, and we really should be engaging those students in some of our work.
I love that idea.
I do too.
Jeff has a comment. It sounds like we need to fairly radically reorient our approaches to diabetes. How quickly are these new approaches being instituted among diabetic educators, dietitians, centers, primary care practices, et cetera?
Very rapidly in terms of diabetes treatment. The new medications are just changing everything. Like people are saying we aren't going to need bariatric surgery anymore because we have these new medications. I don't think that's entirely true, but it's hard to keep up. And one of the things we're doing here in Rhode Island is we've proposed and are planning on starting a diabetology fellowship for family docs so that we can give people an extra year of training in how to manage diabetes. Those docs who are trained in diabetology are expected to go out to practices and support their colleagues in staying up to date and current around managing diabetes. So that's one way. For diabetes educators, dietitians, there's actually a fair amount of resistance, particularly to the keto diet. It's so antithetical to what they were trained on. low fat. Okay, now we're going to do keto. It's the opposite. It's hard for people to make that change. People have been practicing for a long time. Some of them won't make that change. So part of our job is to make sure that the schools are training new diabetes educators and dietitians with these newer strategies and understanding who they might be useful for, who they might be dangerous for, and how to use them effectively. And I think that's still not happening, but we're working on it. The American Diabetes Association has until recently not embraced keto diets, but recently added low carbohydrate as an option for patients who are struggling with type 2 diabetes. And NIH historically has refused to fund keto research, has now started to fund keto research. So there are things that are changing rapidly that are making this easier for us to do, but it's still a constant a debate and discussion about the risks and the benefits in a very high risk and very expensive population and very, very common kind of patient.
It sounds like a nice collaboration also might be with the College of Health Sciences at the University of Rhode Island, which has a nutrition department.
Exactly.
That's great. Hey, thank you so much. This was absolutely terrific, extremely interesting. I just want to point out that next month we're going to have two of our emerging investigators who have been awarded research grants from RI-CTR talking about their research. And that will be on October 12th at 12 to 1 p.m. And thank you once again, Caroline. Appreciate it.
Thank you.
And if you get a request for a survey, please fill it out. We appreciate it. Thank you. Bye-bye.